Very good morning and welcome to all of our viewers today for the Houston Methodist DeBakey Heart and Vascular Center Grand Rounds. I'm accompanied here with Dr. Nadia Fida, who's my colleague and the medical director of the heart failure program at our Baytown Methodist campus. And today I have the distinct honor of introducing our Grand Rounds speaker, Dr. Gregg Fonarow. Dr. Fonarow is the Eliot Corday Professor of Cardiovascular Medicine and Science at UCLA. He's currently serving as the Interim Chief of the Division of Cardiology, but has been the Co-Chief of Clinical Services for many years. He's the Director of the UCLA Cardiomyopathy Center, Co-Director of the UCLA's Preventative Cardiology program, and his research interests have been centered on acute and chronic heart failure, preventive cardiology. He's a guru in quality of care outcomes and has implemented and assisted implementation of treatment systems to improve clinical outcomes. Dr. Fonarow has published over 1,400 research studies and clinical trials in heart failure, disease management, preventive cardiology, and outcomes research. And for many years, since 2014, he has been selected by the Clarivate for the list of highly cited researchers, which identifies the world's most influential contemporary researchers across 21 scientific fields with the greatest number of published articles. Dr. Fonarow has received a Clinical Research Forum Distinguished Achievement Award in 2015. In 2017, he received the AHA National Chairman's Award, and in 2019, he received the Outstanding Lifetime Achievement Award from the AHA Quality of Care and Outcomes Research Council. In 2020, Dr. Fonarow was invited to be a member of the Association of University Cardiologists, which is an elite group of academic cardiologists, only 135, that are included by invitation only. And these are just a few of his achievements, and Dr. Fonarow has really shaped the quality of care, Get With the Guidelines initiatives with AHA, and probably is indirectly responsible for all the improvement in the quality care in heart failure across the country. So with no further ado, thank you very much for taking time to be here, especially being early for you in the West Coast, Dr. Fonarow. I'll hand over the podium to you.
Great. So real pleasure to be here. Thank you for that kind introduction, and delighted to be talking about a topic I'm very passionate about, optimizing quality of care and outcomes for our patients with heart failure. Here are my disclosures related to this presentation, so please do keep these in mind. Heart failure really remains a major public health problem in the US and really globally, with substantial morbidity, mortality, and healthcare expenditures. Now, fortunately, and particularly for heart failure with reduced ejection fraction, we have a number of evidence-based and guideline-recommended and also high-value therapies that are available to treat patients with established heart failure, as well as therapies which can prevent heart failure in the first place. However, study after study in clinical setting after clinical setting shows that there are large gaps in the use of these therapies, variations and disparities. And thus, as a result, individuals are developing heart failure and having fatal and non-fatal events that could have been prevented with better implementation. So as we think about the domains of outcome research, we've actually had a lot of success in heart failure, but also challenges. Figuring out through discovery science, remarkable discovery science, what works for individual patients and populations of patients. But an essential step is that translation of that discovery and knowledge into actual routine clinical practice, getting what works implemented fully in patients and populations. I'll show you there have been challenges there, but a tremendous opportunity. It's also important to keep in mind preference, so patient alignment, so applying therapies in a way that are truly patient-centered. But if we do this well, we can optimize quality, we can markedly improve patient-centered outcomes and provide care at high value. So as we look at recent statistics for heart failure, we can see there's a lot of work to be done. 6 million men and women in the US with heart failure, over 1 million new cases of heart failure will occur this year. And the mortality by the natural history remain high, close to 400,000 deaths a year. Large number of hospitalizations where heart failure is a primary discharge diagnosis, but another 3 million to 4 million where heart failure is a secondary diagnosis. And as I've highlighted, despite the treatment advance, we still have a large number of eligible patients not receiving one or more of the therapies that have actually been shown to be able to reduce all-cause mortality. We can do so much better for our patients. Now, if we look at some recent statistics, I think it becomes clear that these outcomes are not ideal. So why in-hospital mortality for a patient hospitalized with heart failure, whether de novo or an exacerbation of existing heart failure, remains relatively low, the readmission rates are incredibly high. Half the patients rehospitalized one or more times in the first 6 months. And after a heart failure hospitalization, fully 1 in 3 patients don't survive the full year. If we look at data with regards to median survival compared to the general population, this is data from fee-for-service Medicare beneficiaries and Get With The Guideline heart failure, even for those aged 65 to 69, that after onset of heart failure, there is a median loss of survival compared to the general US population of over 15 years loss of life. And even for individuals 90 and above, there's a 4-year loss of life. So how can we go about giving back that loss of median survival concomitant with having heart failure by its natural history through the use of our evidence-based therapies? Now, fortunately, through discovery science and remarkable randomized clinical trials, there's actually been the demonstration we can not just make patients feel better, keep them out of the hospital. Actually, these therapies are strong enough and proven compared to placebo or active comparator to be able to reduce all-cause mortality, to extend survival of patients. And you can see the relative risk reductions in all-cause mortality shown here. You can see in absolute terms, because these patients are at such high risk, the absolute mortality reductions, and thus the number needed to treat over the duration of trial or standardized for 36 months are all highly respectable. That these therapies also lower the risk of hospitalization for heart failure rehospitalization. And these therapies are actually incremental and additive to each other. So if you think about the time period that these therapies have become available, proven in trials, integrated into the national guidelines, you would imagine I'd now be showing you how survival for patients with heart failure has improved remarkably over this time period. But what's so striking, if we now look in community settings, here from Framingham, here from Olmsted County, and looking at patients with heart failure in the community, and looking at 30-day, 1-year, and 5-year mortality, there have been some modest improvements over time, but nowhere near the kind of dramatic reductions in mortality that we've seen in the randomized clinical trials. Recent data from Olmsted County, where they weren't able to demonstrate after the onset of heart failure that mortality, whether cardiovascular or all-cause mortality, had really meaningfully improved. We have data for patients hospitalized with heart failure, fee-for-service Medicare, dating back to 1992 to present, and we look at 30-day and 1-year mortality risk, and there's been this very slight reduction over time, even when we attempt to risk adjust. We're not seeing the kind of large improvements in survival we'd expect with having these therapies available. This is data from the UK, very recent, looking at 1, 5, and 10-year survival, despite the availability of therapies with remarkably established efficacy in heart failure with reduced EF. Morbidity and mortality remain high. Yes, the trends for survival had statistically significant improvements, but you can see the magnitude of benefit here over time has been really modest. So what's going on to potentially explain this? And the answer is a failure in our translation of evidence and guidelines into routine clinical practice in all settings. So here's data. This looks at 15 different countries, 1,300 different clinicians caring for patients with heart failure, all demonstrated to have reduced ejection fraction. Any patient with a contraindication or intolerance removed from the denominator. And we can see in a time frame for first 3 classes of medications demonstrating improved survival. These marked gaps in the use where eligible patients without contraindications were not being treated despite the survival advantages offered by these therapies. Here's data in the 2004 timeframe from Canada. Patients hospitalized heart failure, reduced ejection fraction. Again, any contraindication or intolerance, those patients were removed. We can see a little better use of ACE inhibitor ARB, but still about 1/3 of eligible patients not being treated. Beta blockers are single most important survival enhancing medication for heart failure, 2/3 not treated. Now you can say that was at hospital discharge, but in 90-day follow-up, we see very little change in the therapy. And further, we see those at highest risk for mortality using a validated risk score actually were paradoxically less likely to be treated with the guideline recommended therapy, even though they were more likely in absolute terms to benefit. So we have treatment gaps that begin in the hospital and continue in the outpatient setting. We've got risk treatment mismatch where those at highest risk for mortality are paradoxically less likely to be treated. We also have marked variations and disparities in the use of evidence-based therapy. We've seen it for medications. Here I'm showing it for use of ICD in heart failure patients and meet all the guideline criteria for a preventative ICD to be placed. And what we can see by the virtue of overall treatment gap, but by virtue of race and sex, certain patients, even when you adjust for comorbidities or even insurance status, are less likely to be treated. So we have race and sex-based disparities in the use of our evidence-based guideline recommended therapies. Here's data from the ADHERE registry, one of the first national heart failure registries. And this was looking now at measures that CMS and the Joint Commission said we're going to publicly report, release a part card for these process of care measures. So hospitals recognized they were being graded on this. And you can see for certain metrics like measuring ejection fraction and having that recorded in the medical records, high conformity. But for other things, use of evidence-based therapy, providing comprehensive discharge instructions, smoking cessation counseling, much larger gaps. Lest you think this is only a problem in our community hospitals, look at the academic medical centers participating in here. We had every bit as large of gaps. Those centers entrusted with training the next generation of physicians, the quality of care being provided, the examples being provided to trainees, we see large gaps. Now, here's the variation, and it's incredibly striking. So, host of trials demonstrating the benefits of ACE inhibitor ARB and those with heart failure with reduced EF. Again, these are eligible patients without contraindications. Each one of the bars is the hospital performance on this measure of discharge. And what we see here is this huge variation. Now, there's some good news in this. Some hospitals, 100% reliable care, day in and day out. Their eligible patients without contraindications or intolerance were discharged on an ACE inhibitor ARB. But there were some hospitals where not a single patient was treated. What accounts for that variation? Were these just hospitals where patients had more comorbid conditions, renal dysfunction or otherwise? We really saw no evidence of that. It really seemed to center on whether there were clinical decision support systems, a culture of quality and safety at those institutions. So how can we reduce this variation and elevate the performance of all hospitals? They're clearly achievable benchmarks showing highly reliable care can be provided. Well, does it matter? So this is looking at lagging and leading centers and ADHERE, and look at the striking difference in the Joint Commission for process measures at the time that this analysis was done. So really striking between lagging and leading centers. Now you can say, hey, let the clinicians do what they want. Does this really impact quality or outcomes? But we did see the association here with efficiency of care and mortality for these patients. So decrements in quality care may lead to decrements in outcome and improving quality, perhaps better clinical outcomes. So if we look across settings in the usual care of heart failure, there's a lot of failure going on. Failure to clinicians to prescribe evidence-based medications to eligible patients, failure to discontinue medications like NSAIDs that can exacerbate heart failure, failure to up-titrate those medications where there's good evidence for titrating to target dose, failure of patients to adequately adhere to therapy, failure to consider device therapy, all the other aspects of care, providing adequate follow-up, monitoring, social support systems, and addressing patient and caregiver needs in a patient-centered way. So how can we take some of this failure out of the usual care of heart failure and elevate quality and ultimately outcomes? Well, importantly, we need to have a perspective on the reasons for the underutilization of evidence-based therapies. Clinicians are not reporting to work today saying, wow, I'm going to do perfectly mediocre job in the care I provide. So some of this reflects gaps in knowledge and awareness for which education may play an important role in providing clinical decision support about eligible patients and the magnitude of benefit that can be achieved. But a lot more of this is a lack of systems, totally being dependent on whether a clinician happens to remember, with a lot of distractions going on, a specific therapy is indicated, the right dose, right time, and this right patient. Clinical and therapeutic inertia play an incredibly strong role here. Oh, we'll delay the therapy till they're outpatient. Oh, till the next visit, and patient going on to have an event that could have been prevented had therapy been started early. Some of it may be, I'm aware of the clinical trial data, but I don't think it applies to the patient in front of me. So is the efficacy in trial really translating to real world effectiveness? The older patient with more comorbid conditions, do I believe this therapy will benefit them? Concerns about tolerability and side effects and safety. Some of this may reflect outright bias regarding the patient's age, sex, race, ethnicity, socioeconomic status. So we'd have to overcome those biases. And then there are legitimate concerns with certain therapies about access, prior authorization, cost, and the value of therapy. Can that patient afford the out-of-pocket expenses? So we really need to address each of these if we're going to meaningfully improve quality and outcomes. So how can we bridge the gap between our knowledge and what occurs in routine clinical practice? And this is where systems of care can play an incredibly important role. And I'll show you the data that really supports us of systems to help us implement the evidence-based care, improve coordination across all the clinicians involved in care and the patient and their families, ensure adherence, and then ultimately improving quality of care in a way that would translate to meaningful improvements in clinical outcomes. Now, we and others have been involved with creating highly specialized teams of heart failure specialists with advanced practice nurses, creating a whole multidisciplinary team focused on comprehensive assessment, also consideration of advanced therapies. But a fundamental nature of this was to really optimize the heart failure treatment regimen and the follow-up and monitoring of these patients. And we and others have been able to show through these multidisciplinary teams, you can make really meaningful and sustained improvements in the use of guideline recommended therapies for patients with heart failure with reduced EF, and that this translates to improvement in symptom status and clinical outcomes in a really remarkable way. And this has been shown in randomized clinical trials. And does this improve outcome? This is data from UCLA looking as we applied more and more therapies becoming available, those extensive, large reductions in mortality were actually achieved. So you follow the evidence and guidelines, ensure it's translated in clinical practice. Here in a single center, we see the kind of large mortality improvements that we would expect. And here's randomized clinical trials of specialty-based heart failure disease management programs showing reductions in hospitalizations for heart failure, and many, but not all, showing reductions in mortality. So we have a strong evidence base for this being an effective way of managing our patients with heart failure. So what's the drawback with all of these benefits of heart failure specialty disease management programs? Well, the challenge, despite the evidence and guidelines, is that a rather small proportion of patients with heart failure are managed in such programs. They're difficult and challenging to create, the access. And so having something that's going to be more sustainable and scalable to the whole contingent of heart failure patients is important, why we also work to expand access to our heart failure disease management programs. So the last 20 years, we've been very interested in utilizing hospital-based systems for heart failure management. Even though this can be a chronic disease, largely managed outpatient, can we take hospitalization as a patient capture point, a teachable moment in that patient's care, and try and accelerate the use of evidence-based therapies by getting them started in hospital, and take advantage of hospital structure where there's standardized processes, protocols, already pre-existing multidisciplinary teams, and accrediting bodies for standards of care, and already the beginnings of public reporting of metrics. So we were able to demonstrate a useful way we can improve the use of care with a hospital-based system, but could this work elsewhere? So working with Intermountain Healthcare, 10 hospitals on a hospital discharge checklist, you can see their ACE inhibitor ARB used to baseline pre-intervention was similar to that of the rest of the US, but post-intervention using a standardized discharge checklist for the med, remarkable improvement in a short period of time to 95%. And yet we saw then this translating to a reduction in readmissions and one-year mortality. Could we scale this up even further? So Optimize HF, designed as a national performance improvement program for patients hospitalized with heart failure, involving hospitals of diverse type all across the country, to improve medical care and education of patients hospitalized with heart failure and accelerate the initiation of evidence-based heart failure therapies by starting these therapies in hospital and ensuring before discharge appropriate patients were treated, as well as understanding the patterns of care and remaining barriers to move the field forward. So here are the hospitals participating in Optimize HF, all regions of the country, all types of hospitals, predominantly community, some academic, transplant centers, had a web-based registry to capture this data and process care improvement program, a customized toolkit based on the evidence and guidelines, but could be truly personalized for each center and clinicians to make this really actionable. So algorithms, care paths, standardized orders, patient education, and importantly, educational opportunities to interact with national faculty that help create the guidelines and understand and get questions answered, and then be able to support the cycles of quality improvement, get real-time feedback on the care being provided, see if achieving goals, if not, further refine the protocols and support this. We were able to demonstrate for each of the metrics, but one, really meaningful improvements pretty quickly by quarter. So a large use. You can see for beta blocker use right off the bat, we got high rates. This is a time frame that I showed you the Canadian effect study where only 1/3 of patients were being discharged on beta blocker. Here we're up at 75% off the bat and up to 85% towards the end. So really making meaningful improvement in quality care simultaneously on multiple metrics, whereas prior QI had often focused on only a single metric. Did this matter? We were able to show through the use of the process improvement program reductions in early outcomes, improving in 60 to 90-day mortality, rehospitalization, also significantly improve the quality of care through processes translating to better clinical outcomes. The other thing we were able to show was how critically important in-hospital initiation was. This had become accepted for statin therapy and patients hospitalized with atherosclerosis. But for heart failure, a lot of the thinking was, oh, want to delay till outpatient, more stable, we're worried about adherence. Here you can see for eligible patients, in-hospital initiation of beta blockers, they are at discharge. At 90-day follow-up, patients 30-fold more likely to be treated by the risk-adjusted odds ratio than those that were perfectly eligible but not started in the hospital. And similar pattern for ACE inhibitor ARB. So hospitalization truly a teachable moment for adherence to medication, persistence of the key evidence-based therapies. We were also able to show, although the beta blocker trials had all been in outpatients with heart failure, that with starting in hospital, even though you may have discharged without a beta blocker and started subsequently, the outcome difference with the in-hospital initiation was substantial, seen over 60 to 90-day follow-up, but even by 30 days was highly statistically significant. So improved use of the evidence-based therapy, this early benefit demonstrated beyond the long-term benefit is shown in randomized clinical trials. We were able to show a practice where, a patient hospitalized with heart failure, let's temporarily withdraw the beta blocker without a contraindication or intolerance. That was associated with the worst outcome, but continuation of beta blocker or new initiation associated with better outcomes than ever treated. This led to a change in the guidelines based on the observational data. Now, interesting, we saw, kind of medium doses of beta blockers at the time of hospital discharge, but interesting, over 60 to 90-day follow-up, that clinical inertia kind of crept in where very little change in dosing. So this identified, we did this phenomenal work in getting patients now started on therapy, that made clear further work was going to be needed beyond optimized HF for getting the proper titration to target dose so long as well tolerated. So we were really interested of then looking at, were the process of care measures that were being looked at nationally associated with outcomes. Beta blockers wasn't included in that measure, but we included an optimized HF. Was that a meaningful measure? So we actually studied this. This was reported in JAMA. What we found is really interesting. Those that involve, check the box, discharge instructions, smoking cessation counseling, we didn't actually find an association with outcome. Medications clearly mattered, and the strongest association was actually beta blockers at discharge. So really clear that we needed to constantly update our performance measures to make sure their outcome. Now, there was a lot of pushback about the data at the time, questioning methods and, was there some reverse motivation here? And we strongly believe in our checkbox performance measures. But, ultimately the ACC/AHA did revise the measures to be the actionable ones that were linked with clinical outcomes, and beta blockers were added. So this work really did meaningfully impact the performance measure standards that were utilized and set that stage for utilizing metrics that were really going to be meaningful with regards to, patient-centered clinical outcomes. Now, after finishing optimized HF, we were fortunately able to roll this in and get with the guideline heart failure. Over 2 million patients have now been in this. It has been sustained since 2005, over 800 US hospitals. There's the opportunity for national recognition and integrating additional measures. So it uses a web-based patient management tool. They're AHA specialists that will work with each hospital on their systems of care, clinical decision support. You can interactively check your patient's care with the current version of the national guidelines. And what we've been able to show here, and this is, hundreds of hospitals, tens of thousands of clinicians, hundreds of thousands of patients, that compared to baseline, we've been able to elevate performance across the board for all of these metrics, including the composite performance measure and the all or none measure, getting all of these above 90%, clearly love to be at 100%, but highly reliable and highly sustained performance involving a whole diverse array of patients, clinicians, and hospitals. So a sustainable and scalable quality improvement initiative has been demonstrated to clearly be possible and work on multiple metrics simultaneously and achieve a high level of success. Now you say, look, use must be improving across the country. You may have gotten there quicker. Are we really convinced that it's get with the guidelines that's working here? So using that in a simultaneous time period, the Joint Commission core measures, get with guideline, non-get with guideline hospitals, we see huge differences with regards to conformity. Well, you could say, we're just selecting hospitals that are doing a better job to join, but interesting, no difference in other metrics for quality of care in pneumonia or the surgical quality of care measures was, really centered there on heart failure. We also see better outcomes. And so really suggests that participation in these programs can meaningfully elevate beyond what would occur with just usual care. The other thing we were interested in is, were we just in the short term improving survival, or was this enduring survival improvement? Some data from MI showed it was really just short term, but here we show for heart failure, those hospitals that are high performing and the 30-day outcomes were actually could add much as a year of life back to patients compared to the lower performing hospitals. So these early improvements in the use of evidence-based therapies turn into long-term survival benefits. Now, what about in the outpatient setting? I highlighted how challenging that could be, but could we take the lessons that we learned from hospital-based programs and perhaps apply them to the outpatient setting? Most quality improvement programs in the outpatient heart failure setting have actually not been successful. So we were interested in taking this on, but recognizing the challenges here. Think about the hospital resources. Yet in the outpatient settings, often the physician seeing the patient on their own with 15 minutes at best to spend with that patient without the multidisciplinary teams. Can we really take advantage of everything that we learned in the inpatient setting, make some meaningful improvement outpatient? So that was a rationale behind IMPROVE-HF, register and improve the use of evidence-based heart failure therapies in the outpatient setting. So utilized all of those best practices and knowledge from the hospital-based setting, but track utilization via chart reviews for medication devices, patient education, identify treatment gaps, feed that back to the clinicians, provide comprehensive clinical decision support. 167 US cardiology or multi-specialty practices actually enrolled 35,000 patients, the largest quality improvement initiative as a single entity in the outpatient setting that I'm aware of. And so here was the design here. We actually use highly trained chart abstractors to collect that data at the same level of rigor as used in clinical trials, fed back that data to clinicians, average of 90 patients per practice, and would track that data back to the clinician. So a baseline chart review, and you could see your benchmark performance at the practice level as well as individual physician level. And then looking at whether there was meaningful change at 12 months and 24 months. And then for new patients coming in the practice, 6-month and 18-month chart review. So total of 63,000 reviews, 34,000 patients enrolled, 782 site visits. So incredibly resource intensive, but we wanted to see if we really with rigor could demonstrate improvements. So the workshop after the data was collected at baseline to really highlight the evidence guidelines, academic detailing, providing a guideline-based clinical decision support tool that can be customized for each physician practice. And then importantly, web-based quality reports fed back to clinicians. So all of the clinical decision support, all of this has been made available publicly, but was there for the practices to really customize and utilize chart stickers, checklists. The web reports, you could drill down to not just each measure over time compared to benchmark to other practices, could drill down to the individual clinician or patient. Show me the list of all my patients, heart failure, reduced EF, not on a beta blocker without contraindication. Let's call them in and get them started. So made this data actually actionable. So here's baseline performance. Recognize these are cardiology multi-specialty practices. So the baseline performance started off at a higher rate of some of the other studies I showed you, and some even raised the concern at 86% ACE inhibitor ARB beta blocker. Could we be at a ceiling effect? Would it be too difficult to improve any further? You can see for other things like MRAs, a much larger treatment gap, CRT, ICD, even heart failure education. So did the intervention, the outpatient setting, actually improve performance? And for 6 of the 7 pre-specified measures of which we'd said would need to have a relative 20% improvement in at least 2 measures to meet the primary endpoint, we were able to demonstrate in 6 of the 7 measures really meaningful improvement. Even those that start off high, further improvement, ACE ARB going from 80% to 87%. We can see beta blockers up to 94%, doubling the use of MRAs, 34 to 64%. CRT ICD improved. Now, anticoagulation for AFib did not improve, so not every metric improved. This is before the NOACs were available, but we could see for 6 of 7 measures, meaningful improvement at 12 months and further improvement at 24 months. Here are the absolute and relative improvements. You can see we exceeded that 20% relative improvement in multiple measures and even had absolute improvements that were very large and statistically significant and clinically relevant. Using an all or none metric, so at baseline, it was 23% of all eligible measures applied. This increased at 24 months to 68.7%. We're happy if we could move the all metric by 2 or 3%, but here we saw this really large and meaningful improvement, 345% relative increase in this all or none metric. So large improvements were able to be achieved. Now, those in the quality space recognize you can make performance measures change and improve in two ways. One that's, patient-centered and good, more eligible patients identified and treated. But the other way you can make performance improve is more patients being identified as having contraindications or intolerance and take them out of the denominator. So it was really important we demonstrate this was actually net improvement of eligible patients being treated. And you can see that's in fact what drove the improvement for each of these measures. So these were truly eligible patients that just had not been treated with the clinical decision support and Improve HF initiative were now able to be treated. Now, in looking at variation, we were able to markedly decrease the variation for each of the measures. Interesting, this was elevation in performance, whether starting off low, medium, or high in performance, except for those that were already at 100%. So really helped elevate the overall practice performance and Improve HF rather than selectively just the lower medium performers in that regard. Now, with regards to target dosing, we did focus on this more. You can see for beta blockers some meaningful improvement, but still gaps remain to getting to 100% of target dose. So clearly, even after Improve HF, further efforts are going to be necessary. Now, importantly, we were interested in not just reducing variation, elevating overall performance. What about those disparities in care? If you focus on elevating overall performance, can that reduce disparities? So long-standing data about women not being equally treated to men. We saw this at baseline in Improve HF. Post-intervention, though, meaningful improvements in both men and women. And in fact, for 5 of the quality measures, similar achievement at 24 months, but actually CRT and ICD and composite care, women's care, quality exceeded that for men. So really we're able to eliminate the sex-based disparities in heart failure care, at least in the context of these metrics that we were looking at in Improve HF. And so you can see the overall improvement in composite or all or none quality by patient sex. So really remarkable in that regard. What about race-based differences, disparities shown? I showed you that for ICDs. With the guideline, we see data here. Similar with regards to Improve HF on the basis of race disparities in use. A busy slide, but basically we were able to show large improvements for Black or white or those where race and ethnicity were not documented in Improve HF. And so really large and meaningful improvements in the disparities at baseline, at least for these metrics in the context of Improve HF in these patients, we did see a reduction or elimination of the disparities that had been there at baseline. So more equitable care provided through these type of approach. So does the increased use of guideline recommended therapies actually improve clinical outcome, right? A fundamental piece of information for those writing the guidelines want to know that they make a meaningful difference. For heart failure, that really had not been demonstrated, but fortunately in Improve HF, we were able to look at this. And what we show for these process measures the use of the evidence-based therapy here for 24-month mortality, meaningful association with improved clinical outcomes. So able to demonstrate guideline concordant care associated with better 24-month survival for patients with heart failure in the real-world clinical practice setting. And in fact, when we look then at a composite of guideline conformity, each 10% improvement in ACC/AHA heart failure guideline recommended composite care was associated with a 13% lower odds for 24-month mortality. So the clear demonstration that guideline-directed medical therapy and device therapy for heart failure in the real-world clinical practice setting improves clinical outcomes, including survival. Now, when we look at the cumulative and incremental benefits of therapy in trials, right, each successive therapy has shown benefit. But how does that play out in our actual patients? So we're able to look at it in the context of the study, and you can see that for the heart failure therapies, this really large and meaningful improvement that totals like 83% reduction in all-cause mortality compared to being on 0 or 1 of these therapies. So we're really seeing this cumulative benefit following the guidelines patients that we care for in routine outpatient clinical practice translates to really large benefits in clinical outcome. So the clinical implications here are really, in my perspective, meaningful. In one of the largest outpatient cardiology quality improvement programs, we demonstrated implementation of this defined, scalable, sustainable performance improvement initiative intervention could improve the use of evidence-based guideline recommended heart failure therapies in cardiology and multi-specialty practice settings. And so really making the case in every care setting where we see patients with heart failure, programs to provide clinicians with useful reminders based on the guidelines and to continuously assess the success achieved in providing these recommended therapies to eligible patients should really be the standard of care and should be implemented in each of these settings and should be incentivized and rewarded for doing that. And so to really highlight why this is so important, we'll now go back to the clinical trials over the last 20 years in heart failure with reduced EF and look at the actual control arm, the placebo arm. And what we see is for those patients getting placebo in these trials over the last 20 years, it's large reductions in cardiac and all-cause mortality. Why would that be? Well, to get in the randomized trial, care is standardized. It requires by study protocol the patients be on the current standard of care, the evidence-based guideline recommended therapy before enrollment for the experimental therapy. And so we see huge benefit. But yet here, when we look at Amstead County, specifically for heart failure with reduced EF in the community setting where there is no standard or requirement or protocol that must be followed, we've seen in that same time frame very little improvement in survival. So we can be so much better if we made our standard of ensuring that in every setting, these eligible patients are actually treated in the absence of contraindications or intolerance. Now, clearly, although we've demonstrated this can be done, there are challenges to implement heart failure performance improvement systems. Here are a whole lot of reasons that are commonly cited of, oh, that data is great, but why we can't do it here? You know, administration won't pay for it. What about the liability? It'll take too much time. My patients are too complex for this. We don't have any personnel that can do this, but showing you these barriers can be overcome and can make a meaningful impact on quality and outcomes. So why do some programs sign up and improve and have great success and others sign up? You don't see that much change. So really the access to current and accurate data on treatment and outcomes that clinicians believe is accurate, having stated goals, getting administrative support is critically important. Support among clinicians, champions that really are passionate about and lead the effort locally. Use of clinical decision support, and importantly, use of data to provide feedback to those clinicians, hopefully at the point of care that they can really act on and make meaningful differences and get the feedback of when those improvements are actually made so they can be sustained. So where do we stand now? We took a more recent snapshot of heart failure outpatient care 10 years after improved HF. Here's CHAMP HF registry at baseline. And what we see, wow, you know, some improvement in ACE inhibitor ARB use, but still some gaps remain. MRA therapy, wow, you know, only a third of eligible patients being treated. And, you know, when we look at target dosing, well below, and when we ask the question among eligible patients for all three major classes at the time this study was done, that were on target dose, only 1% were simultaneously receiving the full set of therapy. So, you know, we really have gaps that remain in these different settings. Here is clinical inertia personified. This is following patients now over 12 months of outpatient visit after visit after visit, where the medications are not being initiated or not titrated despite class 1 recommendations and the guidelines, and in the absence of documented contraindications or intolerance. So we need to break this cycle. We need to have clinical decision support and meaningful performance improvement in every setting. To highlight this further, how the outpatient setting can be a challenge, this is the recent Connect HF with the idea of, you know, can use some digital tools and feedback to the clinicians at the top level after hospital discharge through 12-month follow-up. And we really didn't see an improvement in use of therapy, the dose of therapy, or clinical outcomes. So it just highlights how incredibly challenging this can be and how critically important that we get therapy started in hospital prior to discharge, and that we break this cycle of clinical inertia in the outpatient arena. Now, certainly cost is an issue, but I do want to highlight, look, for certain therapy, beta blocker aldosterone antagonist, it's $40 a year. So clearly cost doesn't explain why only 1/3 of eligible patients are on MRA. Clearly for some of our newer therapies, sacubitril, valsartan, SGLT2 inhibitors, higher cost there, but legitimate question about the value that therapy provides. So to really answer that, this is an analysis with Muthu, Vagnathan, and others that we published in Lancet, where we wanted to ask and answer that question, well, is it well enough that the majority of patients with heart failure reduced EF are currently on an ACE inhibitor, ARB, and beta blocker, and that sort of it? Or what's the magnitude of benefit being left on the table by not having them on comprehensive disease modifying, life-prolonging therapy of sacubitril, valsartan, MRA, SGLT2 inhibitor, and the beta blocker? And so you can see the relative risk reductions compared to that prior standard of care to more comprehensive treatment. These are large relative risk reductions. But what does it mean to median survival? Well, you can see here, compared to not being on no therapy, being on ACE inhibitor, ARB, and beta blocker, being on the true standard of quadruple therapy could extend median survival by 6.3 years. Think about in oncology, when you have a drug that extends median survival by 6 weeks, there's often $100,000 a year charge for that, or 6 months, $400,000. Here we have therapies that cost a small fraction of that, but extend median survival by 6.3 years, a compelling case of why we need to overcome clinical inertia to apply these therapies in eligible patients. They're cost effective. We need to overcome the barriers about cost and access. Now, there's another barrier that's actually self-imposed by the clinicians and those who actually write guidelines, where have adopted the historical sequence of, start an ACE inhibitor ARB and not titrate over 2 to 4 weeks, then get to target dose, then get the beta blocker. Only after that's up titrated, then think about the MRA. Only after that's up titrated, then think about switching to sacubitril, valsartan, and only at that point think about SGLT2 inhibitors. Well, you map that out, it's 28 to 56 weeks till guideline-directed therapy is fully implemented. And that's as if there's no clinical inertia and every one of these steps is followed. We need to do much better than that. And the critical reason is, of course, these therapies all work within 30 days, markedly reducing cardiovascular death and hospitalization. Delay any one of these by more than a few days, there are preventable events that are happening. And so clinically significant benefits early after initiation makes a sense of urgency and compelling to start therapies and stabilize patients as soon as possible. And at the low starting doses, they can be tolerated. So really have advocated, this is as we published with Steve Crean and Javed Butler and JAMA Cardiology, of in eligible patients, hospitalized or outpatient, of trying to start either low dose simultaneously or in a very rapid sequence, ASAP, each of these therapies, why there's early benefit, then focus on up titrating the beta blocker that has the steepest dose response curve, the other therapies as well tolerated, then can focus on comorbidities, consideration of device therapy and otherwise, but really have that main and urgent goal, the complete set of comprehensive disease modifying medical therapy being implemented, quadruple therapy, and each of them have demonstrated significant benefit. And you add that up, it's a 75% reduction in cardiovascular death or heart failure hospitalization the first 30 days of getting these therapies implemented. And the benefits go beyond mortality reduction, rapid improvement in EF, reduction in hospitalization, rehospitalization. You're concerned on your 30-day readmission metric for heart failure. For heart failure reduced EF patients, get a marked benefit of getting these therapies started. And this also markedly improves adherence. So I've highlighted starting all 4 classes of meds at diagnosis, in hospital initiation, performance improvement systems like Go With the Guideline, Heart Failure, Improve HF, multidisciplinary heart failure disease management programs. There are other programs being investigated, guideline-directed medical therapy clinics, telehealth, digital tools, patient activation programs. So certainly we need more efforts, more research on facilitating guideline-directed medical therapy implementation for all eligible patients in all settings to translate our evidence into practice. What would happen if we did this optimally nationwide? This is a number of lives that we could save just by applying our existing therapies implemented. And you can see for each and every one of these optimally implemented, the number of lives saved per year is really remarkable. Add this all up, over 130,000 additional lives could be saved beyond our current performance for heart failure care with optimal implementation. So really worth the time and the effort and the investment to get these lives saved through optimal implementation. So the role of learning health systems really has been highlighted more recently, whether quality improvement systems, learning health systems, to take our clinical evidence guidelines, have actionable performance measures, provide measuring feedback, and ensure we're applying the therapies and improving patient-centered outcomes that can generate new hypotheses in a virtuous cycle here. So here's a quote from Bill Gates that I really like. Humanity's greatest advances are actually not in its discoveries, but in how those discoveries are applied, the implementation of our evidence-based therapies. So to summarize, the approach to heart failure burden continues to grow, one of the single most deadly and expensive healthcare problems. Fortunately, I have medical therapy and non-pharmacologic measures for heart failure that can impact patients' quality of life, need for hospitalization and rehospitalization, cost of care, health status, and their survival. But they're unfortunately underutilized in many conventional practice settings, showing you that hospital and outpatient performance improvement systems, as well as specialty disease management programs, can markedly improve care and outcomes. And we need a more focused approach, and the optimal approach for guideline-directed medical therapies to utilize each of the life-saving medications in combination, so long as not contraindicated and not tolerated, and start each without delay. Have the sense of urgency our patients deserve, apply the systems our patients deserve to truly implement those therapies that can make a meaningful improvement in our patients' survival. With that, thank you so much for your attention today, and I'll be delighted to answer any questions.
Dr. Fonarow, thank you for the great and very engaging presentation as usual. It is appalling to see these pervasive gaps in the optimal uptake of the contemporary treatments that can actually improve survival of the patient. You have highlighted several issues that widen these gaps in the uptake of guideline-directed therapy and methods like audit and feedback and behavioral modification. My question is, where do you see, or in which setting do you see that the most opportunity lies for these implementation interventions to be most effective?
Yeah, so certainly the hospitalized setting has a number of advantages, right? You've got the patient's attention. There's strong data when we start the therapies in the hospital, they stick with the patient. It sends a message. This therapy was so important. My physicians, my nurses would not send me out of the hospital without it. So that becomes a really important teachable moment. But many millions of our patients are outpatients. So we need to have that ability in the outpatient setting to really make meaningful improvements. So really in all of these settings, it's really critical to empower all of the clinicians and to engage patients as well. And so we can begin to think with digital strategies of engaging patients at home to get therapy started, that we don't need to be dependent on an outpatient physical clinical visit, but actually do it virtually.
So much for that overview, and I want to thank you for all your efforts in implementing this whole evidence over a period of many years that actually makes us implement some of these interventions that you have published. So definitely we appreciate that. I want to remind our audience that you can send in questions through pollev.com, where you can enter DeBakey, or you can text DeBakey to 37607. And I'm going to move on with some of my questions, and I've been integrally involved in some of these initiatives here in the hospital, and I understand how painful it is from the transition of the knowing what needs to be implemented to actually implementing it. So I think some of your data shows impressive improvement. My question is, I think the yardsticks that have been created for us to measure ourselves are probably the beginning of the journey for implementing. And Get With The Guideline has done a phenomenal job in providing that yardstick. But do you think with the wealth of information you have, that there will be a day where you'll be able to give a prescriptive formula how to implement it so that you can then show the results? Because right now, when we look at the yardsticks, each institution is left to themselves to figure out some of the solutions, which can be very unique.
Yeah, so actually, and I didn't get to highlight this as well, part of the Get With The Guidelines is, of course, sharing best practices, where we feature in monthly webinars, hearing from centers that have made meaningful improvements and them sharing how they did that. And there's a team of AHA specialists that actually go out and work with hospitals to help facilitate it. So there are opportunities there. I think you're getting at this issue. Can we get even, more technology enhanced to utilize the information from this whole network of participating hospitals and data being collected by patient that are entered, and understand the patterns better, and more rapidly sort of recognize best practices and push those out and help disseminate them. We're beginning to think about ways. And there's work going on about providing really highly customized dashboards to clinicians right as they're seeing the patient, or providing them prompts. There's going to be a randomized trial. Eric Ahmed is going to present at ACC as a late breaker that looks at a really, highlighted, high-level support for GDMT in the electronic record to prompt clinicians to actually prescribe those therapies and show all the things that go into the eligibility. And we'll see whether that made a meaningful difference or not. So there's a lot of work going on to try and make this as user-friendly for the clinician, as actionable. Larry Allen worked on a project where it was actually engaging the patient, letting them know about the key guideline-directed therapies and raising it back now on the clinician with their visit. And that made some meaningful improvements. So I think we need to think about every touch point of making a difference to get these therapies not only initiated, but maintained, titrated, and adhered to long-term, since it makes such a big difference in the patient's clinical outcome.
No, thank you for that. I think you bring up a key point of it's not a single solution. There's like a spectrum of solutions we might have to come up with. And you brought up patient empowerment, which we've kind of invested in it, doing a patient conference, and where there's a research project that Nadia is working with on, can you educate the patients enough so that they actually prompt the health system? In that regard, do you foresee that there should be a public reporting system? As you and I know, public reporting makes a lot of investment that go into it. Is that ever going to happen based on your perception?
So, I think it's interesting, right? We've toyed with this concept of patients getting report cards on their performance, right? So shared accountability for measures. So is the patient adhering to therapies prescribed and, actually taking them? There's some plus or minuses to that. I do think nationally we need to reconsider what happened, that we went from process-based measures, but a lot of health systems complained, it takes a lot of work to collect the data that then is publicly reported. So CMS said, fine, we'll use administrative data and report risk-adjusted outcomes, like 30-day readmission rates for heart failure and other conditions and mortality. But you suddenly realize that's not actionable. The data lags, 3 years ago is what's being reported, and it's based on administrative coding. And so how seeing my risk-adjusted readmission rates from 3 years ago is going to help me now do a better job? What do I act on? So I think we need to go back to actionable process measures being incentivized and rewarded, and potentially back to those being publicly reported as a way of making meaningful differences. We have to have the alignment of incentives for health systems to do the right thing point, rather than just trying to game their administrative coding and make their patients look sicker than they were, because it makes the risk-adjusted administrative outcomes look better. So really important that we have, alignment of incentives and engage patients in this. And we do have patient stakeholders with regards to get with the guidelines. The AHA has done a fantastic job with that. But, really engaging patients and their caregivers in this process of quality improvement is critically important.
No, those are phenomenal points, and I'm glad people like you are working on these global solutions, because it's the generalizability of giving incentives for institutions and physicians to be able to do it. Even though all of us mean well, we know that in real life the gaps are errors of omission, which are very easy to happen, and so you would see a day where the incentives will align, because right now when you look at quality comparisons between institutions like Vizian database and things which are quality focused, there's a lot of focus on readmissions, mortality in the hospital, and then length of stay. So, and there's no incentive, there's more incentive to fix those metrics, but there's no incentive to look at, hey, is your patient's going home on the right dose of beta blockers? So do you foresee that these larger quality implementers might adopt these perspectives for heart failure care, which are more meaningful for patients?
Well, I will continue to advocate for it in the professional societies like HFSA, ACC, AHA will. I do think we are in an era where some of the entities are utilizing quality measures, but what they really are cost of care measures, and trying to keep length of stay low and prevent readmissions solely on cost rather than trying to meaningfully improve quality. I think, certainly there's the ultimate incentive of keeping our patients alive longer. You don't want to lose your customers in that sense. So there's an economic and business model to be made for really applying these high quality, high value therapies that do such a good job economically for patients. But I agree with you, we need to have much more of the structure of these quality payment programs and quality programs to be patient-centered and aligned in the most actionable ways, to be those processes that meaningful improve outcomes, to where they're very actionable in an immediate sense and very transparent of what I need to do to improve, rather than being more abstract as it is currently.
Well, thank you so much, Greg. We're 3 minutes over the hour. It was a delightful presentation, and your insights are very valuable. I think I see an impact in our organization itself by what you have presented. Thank you very much, and I thank the audience for your attention, and have a good day.